February 15th, 2023, my dad came downstairs and said, "Shaunie, I think I'm in atrial fibrillation." We utilized an at-home device to confirm, and after waiting an hour to see if he would self-convert, we decided to head to the hospital. At the time, we had no great explanation for what may have triggered this. My dad was a healthy and fit individual with no previous significant past medical history. Fast forward 4 months to June 23rd, 2023, my dad was diagnosed with metastatic renal cell carcinoma, which was likely present back in February. At the time, I did not realize cancer and atrial fibrillation were so closely associated with one another. Today, I am looking forward to sharing with you what I have since been surprised to learn about how commonly the two coexist. I have no financial relationships to disclose. This presentation is accredited through the University of Cincinnati James Winkle College of Pharmacy. This slide will be provided for you again at the end with instructions on how to obtain CPE credit. By the end of the presentation, my goal is for you all to be able to recognize risk factors for developing atrial fibrillation associated with cancer, discuss thromboembolic and bleed risk in patients with cancer and atrial fibrillation, and be able to identify a management plan for atrial fibrillation in patients with cancer. Here is a slide of abbreviations I will be utilizing throughout the presentation for your reference. By the year 2040, it is estimated that greater than 26 million patients in the U.S. are predicted to have a history of cancer, and this has been identified as one of many risk factors for the development of atrial fibrillation. A study conducted in Korea demonstrated this association by matching more than 800,000 individuals diagnosed with cancer to non-cancer control subjects. They found statistically more individuals with cancer were newly diagnosed with atrial fibrillation, and this existed throughout the whole duration of follow-up, which was an average of 4.5 years for most patients, but extended up to about 8 years for some patients. This study also found that patients with cancer had a 44% higher risk of developing atrial fibrillation 1 year after cancer diagnosis. However, this decreased down to 8% for patients who were 5 years out from their cancer diagnosis. When assessing the risk according to type of malignancy, this forest plot highlights the finding that all types of cancer were associated with an increased incidence of atrial fibrillation compared to patients without cancer, which is demonstrated by the fact that all hazard ratios were greater than 1. However, the magnitude of the risk did vary by cancer type. The cancers associated with the highest risk of AFib include multiple myeloma, esophageal cancer, leukemia, and CNS tumors. To briefly review, atrial fibrillation is an irregular arrhythmia characterized by rapid atrial rates, generally ranging from 300 to 500 beats per minute. And because the electrical activity does originate above the ventricles, it is classified as a supraventricular rhythm. And this abnormal electrical activity results in a loss of effective atrial contraction. This is reflected by the absence of discernible and regular P waves on an EKG, which is a key diagnostic clue. On the right, you can see a normal sinus rhythm on the top, with clearly visible P waves preceding each QRS complex. Below that is an example of atrial fibrillation noted by chaotic atrial activity and absence of consistent P waves. And AFib often stems from action potentials around the pulmonary veins, but can also be due to structural changes such as interstitial fibrosis that can alter atrial conduction. Patients with cancer are at a higher risk of atrial fibrillation due to several different factors that often overlap. Beginning at the top, many cancer patients are older, and advancing age is one of the strongest risk factors for the development of atrial fibrillation. Next, these patients often have overlapping cardiac and metabolic risk factors such as hypertension, diabetes, or a variety of other pre-existing cardiovascular disease states, which independently increase AFib risk. Cancer is often associated with a pro-inflammatory state. Tumors can release cytokines and inflammatory mediators that can promote atrial remodeling, which makes a person more susceptible to atrial fibrillation. And hypoxia can occur for a variety of cancer-related reasons, whether it be from direct lung involvement or perhaps anemia, which can create cellular stress on the heart. And speaking of stress, cancer-related stress and pain can lead to autonomic nervous system imbalance, which can destabilize cardiac electrical conduction. Additionally, paraneoplastic manifestations, which are indirect effects of cancer, such as tumors that secrete substances like hormones that can irritate the heart. Next, we have cancer invasion of the heart, which of course can disrupt electrical conduction. And then the last two I will spend a greater deal of time discussing throughout the presentation include perioperative causes and anti-cancer treatments that can increase a patient's risk of developing atrial fibrillation. Looking first at anti-cancer treatments, the American Guidelines for the Diagnosis and Management of Atrial Fibrillation have a really nice table that organizes anti-cancer treatments that are most associated with an increased incidence of atrial fibrillation. And this can serve as a helpful reference if you have a patient who is being initiated on any of these therapies. Today, we will take a closer look at the therapies that have the greatest reported incidence of at least 10%, as marked with an X in the right-hand columns. Beginning with the class of medications known as anthracyclines, some of the medications that fall in this class include doxorubicin, epirubicin, idarubicin, and methoxyndrone. These therapies are most commonly used in patients who have breast cancer, acute leukemia, lymphomas, and childhood solid tumors, and their proposed mechanism for causing atrial fibrillation is secondary to cardiomyopathy and LV dysfunction due to direct damage to cardiomyocytes. Additionally, a study conducted in mice suggested that doxorubicin-induced atrial fibrillation was caused by structural and electrical remodeling in the atria. And something to note is that the cardiomyopathy is usually dose-dependent and not reversible. Therefore, adverse effects, including atrial fibrillation, can be seen even after completion of these therapies. The next couple of agents that we will be talking about belong to the class of anti-cancer treatment known as antimetabolites. Clofarabine and cytarabine have been utilized for patients with acute myeloid leukemia and high-risk myelodysplastic syndrome. Together, these agents are proposed to contribute to atrial fibrillation due to the aggressive prehydration that is given to help prevent tumor lysis syndrome, as well as due to potential manifestations of capillary leak syndrome, which is more predominantly associated with use of clofarabine. I am a visual learner, so I really appreciated these cartoon images that help me understand the impact of capillary leak syndrome. Clofarabine can cause cytokine-mediated injury to the vascular endothelium, which can lead to increased capillary permeability. And when this occurs, volume shifts outside of the vasculature, which can cause hypotension, tissue edema, and organ dysfunction, including putting a lot of stress on the heart and lungs. And this image further highlights how unhappy the other organs can be when this occurs. I love how they made the heart the most bossy, yelling to shut it off in the bottom right-hand corner. Look at some of the literature. Federo and colleagues conducted a study comparing clofarabine versus clofarabine plus low-dose cytarabine for acute myeloid leukemia patients or those with high-risk myelodysplastic syndrome, and they found that new onset or exacerbation of pre-existing atrial fibrillation occurred in 17% of patients, with 75% of them being on combination therapy, and this occurred about 5 days after treatment initiation. Agura and colleagues also found that 17% of patients treated with clofarabine and cytarabine went into atrial fibrillation or atrial flutter. However, all episodes were transient and fully reversible with use of diuretics or a beta blocker, which makes sense when we think about the proposed mechanism for causing atrial fibrillation, especially as it relates to fluid overload. I want to highlight a medication, melphalan, that comes from the class of medications known as alkylating agents. Melphalan, in combination with hematopoietic stem cell transplantation, is associated with an increased incidence of atrial fibrillation. The combination is often utilized for patients with multiple myeloma, and melphalan is generally used as the conditioning agent before patients receive a stem cell transplant to help prevent graft rejection and reduce tumor burden. And the proposed mechanism for atrial fibrillation as it relates to melphalan is thought to be due to left ventricular dysfunction, as well as the risk of causing pericardial disease, which puts stress on the heart. And when it comes to the stem cell transplant itself, the risk of atrial fibrillation is thought to be due to the excess IV fluids patients receive after stem cell transplantation, as well as systemic inflammation and electrolyte abnormalities that can occur after transplant. The American Heart Association released a scientific statement discussing cardiovascular complications of patients undergoing hematopoietic stem cell transplantation, And they identified that new onset arrhythmias are the most frequent cardiovascular complication to occur after transplant, with atrial fibrillation and atrial flutter being the most common. The last anti-cancer therapy that I will highlight is ibrutinib. This therapy comes from the class of medications known as tyrosine kinase inhibitors, specifically Bruton tyrosine kinase inhibitors. It is utilized in patients with chronic lymphocytic leukemia. An important pearl for this medication is that patients generally continue the medication until disease progression or if they experience an unacceptable toxicity. And the proposed mechanism for AFib is largely unknown, however, is assumed to be potentially due to inhibition of an enzyme known as C-terminal SRC kinase, or commonly referred to as CSK. And CSK has been found to be enriched in the atria of the heart, and therefore inhibition has been shown to increase the incidence of AFib. Additionally, AFib could be due to inhibition of other pathways such as the PI3K pathway or other parts of the cardiac action potential. And ibrutinib is a first-generation Bruton tyrosine kinase inhibitor, but second-generation BTK inhibitors have demonstrated a lower incidence of AFib, likely due to improved selectivity and fewer off-target effects. To help determine the incidence of ibrutinib-related atrial fibrillation, Baptiste and colleagues conducted a multi-center prospective study. Patients were included if they were treated with ibrutinib and received follow-up in a cardio-oncology clinic in France. EKG monitoring was performed with either a 24-hour Holter or 7-day external loop recorder, and out of 54 patients, they found that about a quarter of them experienced ibrutinib-related atrial fibrillation after about 13 months. The incidence increased to 38% at 2 years, and the risk was found to be 15-fold higher than the AFib risk compared to the general population, as well as patients with CLL who were not exposed to ibrutinib. Interestingly, more than half of them were asymptomatic at the time of AFib diagnosis. Which brings us to our first knowledge check question. Which anti-cancer treatment would you expect to increase a patient's chance of developing AFib even after completing or stopping therapy? Is it A, doxorubicin, B, clofarabine plus cytarabine, C, ibrutinib, or D, both B and C? If you thought A, doxorubicin, that is correct, as the cardiomyopathy is usually not reversible. B is incorrect, as studies have demonstrated AFib to be transient and reversible. And C is incorrect, as it is proposed to impact currents of cardiac action potential, but not necessarily cause permanent cardiac damage. We will now shift gears and discuss another risk factor for atrial fibrillation in cancer patients who have to undergo surgery. There are several factors that play a role in contributing to surgery-related atrial fibrillation, including mechanical stimulation of the pericardium, inflammation following the procedure, use of anesthetic medications, and post-operative electrolyte imbalances. Individuals who are at a greater risk for developing perioperative atrial fibrillation include those with more advanced cancer, those with other cardiovascular comorbidities, older age, prolonged surgical time, or those who have a significant amount of tissue removed. A meta-analysis identified the prevalence of perioperative atrial fibrillation in patients with cancer to be about 13.5%, with the highest risk surgery being thoracic surgery for lung cancer, which makes sense due to the proximity to the heart. And they also identified abdominal and neck surgeries to have high risk as well. Alright, now I'm going to see if I can tap into the creative minds out there and see if you can identify what these images have in common. If you said no two are alike, you are correct. No two snowflakes, zebra stripe patterns, or fingerprints are alike. A similar concept applies for the management of patients with cancer and atrial fibrillation. Each and every patient is unique. There are several different considerations when it comes to managing patients with cancer and atrial fibrillation, beginning with method and status of tumor control, medication adverse effects, which we have touched on a little bit, patient life expectancy, deciding whether patients should utilize rate versus rhythm control for management of their atrial fibrillation, assessing the bleed versus thromboembolic risk, while also accounting for patient preferences, drug interactions, individual lifestyle habits, on top of having a lack of validated scoring tools and various guideline recommendations. Are you overwhelmed yet? I think any single person would be if they had to manage these patients all on their own. Ultimately, these patients require multidisciplinary care, so much so that it is deemed a Class 1 recommendation by the American Atrial Fibrillation Guidelines for there to be multidisciplinary communication, including cardiology, oncology, and other clinicians to reach a shared decision on how to optimize care for these patients. For a large remainder of the presentation, I will be highlighting and discussing recommendations that come from the following guidelines. The most profound guideline, and the one that I was so excited about when it came out in 2022, was the European Society of Cardiology Guideline on Cardio-Oncology. It is amazing for all things cardio-oncology if you enjoy it as much as I do, but most importantly, they have a nice section specifically on atrial fibrillation. Additionally, there's a European and American guideline for atrial fibrillation in general that have a few pearls specific to oncology patients. Additionally, I found these two guidance documents to be really helpful, and I will be discussing some of the recommendations that they provide as well. As I mentioned, each patient is different and management is not black and white. Therefore, I think there is a lot of value reviewing recommendations from both a cardiology perspective as well as an oncology perspective. When discussing guideline recommendations, I wanted to provide this slide as a reference and reminder for how each guideline defines their class of recommendations. In general, a Class 1 recommendation in both sets of guidelines is the strongest and often supported by the most amount of literature, and the strength of the recommendation decreases as you increase in number. In the European guidelines, they have a Class 3 for no benefit as well as a Class 3 for harm, whereas the American guidelines just sort of group this together. Atrial fibrillation management in these patients, there are two overarching clinical considerations: management of the arrhythmia itself and determining whether or not patients need anticoagulation. We will begin by talking about management of the arrhythmia. When a person is diagnosed with cancer, there are many things that we can't control, but as pharmacists, we can be really helpful in identifying potential risk factors for atrial fibrillation that we can control. The ESC cardio-oncology guidelines even make it a Class 2A recommendation that there should be increased vigilance for incident AFib and treatment of contributing factors. Modifiable risk factors that we can be vigilant for include electrolyte imbalances. We generally try to aim for a potassium level of at least 4 and a magnesium level of at least 2. Additionally, being vigilant for the development of fever or sepsis and ensuring adequate infectious disease evaluation. Many of these patients are at a very high risk of becoming neutropenic, so keep Angela on speed dial. And then, as I mentioned at the beginning of the presentation, pain can affect a patient's autonomic nervous system, which can destabilize electrical conduction. Therefore, we can look for ways to incorporate and recommend multimodal pain control. And for this, we will keep Kate Martin on speed dial. Finally, ensuring adequate supplementation of oxygen for patients who develop hypoxemia. Talking about electrolytes inspired my first trivia question for you all. Gatorade, a well-known sports drink formulated with electrolytes, was invented in 1965 by a physician named Dr. Robert Cade. What area of medicine did Dr. Cade specialize in? A. Cardiology, B. Urology, C. Nephrology, or D. Oncology? If you said C. Nephrology, you are correct. True or false? A current physician at the Christ Hospital worked with Dr. Cade. If you said A, true, that is correct. Any guesses on who? If you said Dr. Bott, that would be correct as well. She is a physician that works with the Advanced Heart Failure and Transplant team. Back to another potentially modifiable risk factor for the development of atrial fibrillation. There have been a few different prophylactic treatments tested to prevent perioperative atrial fibrillation. The COP-AF trial investigated the use of colchicine as they thought maybe the anti-inflammatory effects would be protective. The study included patients undergoing major non-cardiac thoracic surgery. Of note, they did not comment on patient cancer status, and overall they found that colchicine did not significantly reduce clinically important atrial fibrillation or myocardial injury, and patients actually experienced an increased risk of non-infectious diarrhea. Therefore, this strategy is not routinely recommended. Wang and colleagues conducted a meta-analysis of several different studies that included patients with lung cancer undergoing lung surgery and identified that beta blocker use, including metoprolol, propranolol, and acebutolol, reduced the risk of AFib from 34.2% to 6.7%, which was statistically significant, therefore supporting the use of beta blockers as a potential prophylactic treatment to reduce incidence of perioperative atrial fibrillation. Lastly, amiodarone has been studied for this patient population as well. Tisdale and colleagues conducted a study that included patients undergoing lobectomy, bilobectomy, or pneumonectomy. And about 70% of the patients had non-small cell lung cancer as their indication for requiring surgery. The study found that perioperative AFib risk decreased by 57% with the use of amiodarone. This study suggests that amiodarone could be another potential option to reduce the incidence of perioperative AFib. However, amiodarone does come with more risks as well as drug interactions. Now that we've discussed recommendations geared toward preventing atrial fibrillation in patients with cancer, we will be shifting towards how we should approach management of patients once they develop atrial fibrillation. Before we dive into recommendations specific to patients with cancer, I want to take a second to highlight some of the recommendations provided in the American Atrial Fibrillation Guidelines that apply to all patients, not just those with cancer, as these are still things to take into consideration for patients with cancer. They have a really beautiful flowchart that I've attempted to recreate that discusses different variables and shows whether it favors use of a rate control strategy or a rhythm control strategy. Patient choice is one of the most important factors, as it is not in their best interest or ours to give them a medication they will not take anyways. And with each patient being unique, there are not always going to be one right answer, so including the patient in the discussion and decision is really important. As far as age and history of AFib, we do have literature that has demonstrated younger patients with a shorter history of AFib tend to do better with rhythm control compared to those who are older and have a longer history of AFib. Additionally, individuals who do not have a lot of symptoms are sometimes okay with utilizing rate control, whereas those who experience a great deal of symptoms feel better with an agent that can keep them in normal rhythm. Additionally, it is important to assess whether a patient is actually able to achieve rate control while they are in atrial fibrillation with the use of rate controlling agents. In cases where they cannot achieve adequate rate control, then it is prudent to consider rhythm control. Finally, there are several factors involving cardiac anatomy that can impact strategy selection, including left atrial size, left ventricular function, and atrioventricular regurgitation. A large left atrium is associated with poorer response rate to rhythm control and therefore may favor a rate control strategy. Patients who are experiencing worsening LV dysfunction by being in atrial fibrillation may require rhythm control. Finally, the presence of more atrioventricular regurgitation can also be a reason to opt for keeping patients in normal sinus rhythm with a rhythm control strategy. With all that being said, the ESC cardio-oncology guidelines do provide a Class 2A recommendation supporting a heart rate control strategy, preferably with beta blockers, as the preferred management strategy in patients who develop well-tolerated AFib while they are receiving active cancer treatment. This will become a little more apparent in a couple slides, but some of the biggest concerns for these patients while they are receiving active cancer treatment is that the cancer treatment itself interacts with our antiarrhythmic options. Additionally, if a patient still has presence of risk factors, whether it be the anti-cancer medication or the cancer itself, that are going to consistently keep them in atrial fibrillation, it may not be worth the patient being on an antiarrhythmic medication that can cause more adverse effects if they will not be able to stay in normal sinus rhythm anyways. At our rate control options, beta blockers are considered the safest to use because they are associated with the least amount of drug interactions with anti-cancer agents as well as anticoagulants. When it comes to selecting a beta blocker, the AHA guidance document does recommend opting for metoprolol over carvedilol, as carvedilol has been associated with more drug interactions. When it comes to our non-dihydropyne calcium channel blockers, diltiazem and verapamil, they do recommend to use with caution because they inhibit CYP3A4 metabolism. And then when it comes to digoxin, they do recommend to avoid use due to the severity of potential drug interactions. Many cancer treatments, including ibrutinib, inhibit P-glycoprotein, which can lead to increased digoxin concentrations and cause potential toxicity. Of course, for all patients, you will want to screen drug interactions, and some medications may not interact with these agents, in which case you may be able to use them, but I do think it is helpful to have in the back of your mind which agents are generally the safest. Discuss our rhythm control strategies. As you can see, there's no green on this slide, which emphasizes that we have to approach each of these options with caution. Beginning with our procedural options, TEE cardioversion and catheter ablation, neither is without risk, and neither is guaranteed to be efficacious or have long-term durability while a patient actively has cancer and is receiving treatment. Additionally, patients have to be able to tolerate the procedure, such as receiving sedation, and in the case of catheter ablation, there is an increased risk of bleeding. When it comes to each antiarrhythmic pharmacologic option, they all carry a risk of drug-drug interactions as well as other disease-related concerns. For example, the Class 1C agents are generally not recommended in patients with heart failure and structural heart disease. Some agents, such as anthracyclines, can increase a patient's chance of developing heart failure, and patients with myeloma having a current risk of developing amyloid. Amiodarone is also notorious for several drug interactions as well as causing QT prolongation. As I've learned through my research project this year, several oncology medications are associated with QT prolongation, and similar concerns are present with sotalol and dofetilide. The medication that the AHA guidance document does generally recommend to avoid is dronedarone due to the severity of drug interactions involving CYP3A4 and P-glycoprotein systems, as well as carrying the concern for QT prolongation and increased concern with other agents that increase a patient's risk of heart failure. Which brings us to our next knowledge check question. Which strategy is preferred in patients who develop well-tolerated atrial fibrillation while they are receiving active cancer treatment? Is it A, rhythm control with amiodarone, B, rate control with metoprolol, C, rate control with digoxin, or D, rhythm control with catheter ablation? If you said B, that is correct. In patients who develop well-tolerated AFib while they are receiving active cancer treatment, the general recommendation for the guidelines is to utilize rate control, and then metoprolol is preferred over digoxin due to a lower amount of drug interactions. Next question, which antiarrhythmic agent is considered to have the most severe drug-drug interactions? Is it A, flecainide, B, propafenone, C, sotalol, or D, dronedarone? If you said D, dronedarone, that is correct. While all of these medications have drug-drug interactions to some degree, dronedarone has been shown to have the most severe drug-drug interactions. As pharmacists, you know it is impossible to memorize all of the drug interactions that exist, but what I hope you get out of this presentation is the importance of screening all patients. I am also hoping these tables can be a helpful reference for you all as they highlight many of the interactions that exist with both rhythm and rate control agents. I really appreciate how they break it down by the effects and whether it increases the concentration of the anti-cancer medication or the rate or rhythm controlling agent. I did highlight the medications that I discussed at the beginning of the presentation that are associated with the highest risk of atrial fibrillation. Doxorubicin interacts with almost every agent to some degree, and ibrutinib interacts with a few agents as well. We will now move on to the other major clinical consideration for these patients, which is anticoagulation. The ESC guidelines call out the dilemma by highlighting the fact that AFib is associated with a twofold higher risk of systemic thromboembolism or stroke in patients with cancer, but the coexistence of cancer also increases the risk of major bleeding and intracranial hemorrhage. So what do we do? One of the most helpful things that we can do is try our best to risk stratify patients. There are a couple of different scoring tools that we can utilize, as well as the acronym TBIP, which is provided in the cardio-oncology guidelines to help guide the decision-making process. And it contains many of the components I have mentioned already, which include thromboembolic risk, bleed risk, drug-drug interactions, and patient preferences, as well as availability or sometimes affordability of the medications. CHA2DS2-VASc score is probably one that you all are very familiar with. This is a scoring tool that helps us to be able to estimate a patient's annual thromboembolic risk. Many risk factors such as congestive heart failure, hypertension, diabetes, vascular disease, which includes a previous MI, age between 65 and 74, and female sex are all given 1 point. However, an age greater than or equal to 75 and previous history of TIA, stroke, or thromboembolism are all given 2 points. And per the American guidelines for atrial fibrillation, anticoagulation is recommended for any male who has a score of at least 2 or a female with a score of 3, because females are automatically given a point for being female. And while we practice in America, I just want to put on your radar that the most recent European guidelines for atrial fibrillation have actually updated the score to just be CHA2DS2-VA and exclude gender, therefore simplifying the recommendation to anybody with a score of at least 2. I'll be curious to see if the American guidelines reflect this change soon. For assessing a patient's bleed risk, both the American and European atrial fibrillation guidelines recommend the use of the HAS-BLED score to help address modifiable bleeding risk factors and to identify patients at high risk of bleeding. This scoring tool generally gives 1 point for each component. However, a couple of the components contain 2 elements that can each count as an individual point. For example, if a patient has both abnormal renal function and abnormal liver function, they get a point for each. Similarly, for the drugs or alcohol section, if a patient is on antiplatelet agents or NSAIDs and they drink more than 8 drinks per week, they get 2 points. I do want to highlight that older age increases both a patient's thromboembolic risk as well as their bleed risk. And a score of 1 to 2 indicates a moderate risk of bleeding, whereas a score of 3 or more indicates that patients have a high risk of bleeding. Which brings us to our next knowledge check question. Which of the following increases both a patient's thrombotic and bleed risk? Is it A, age greater than 80, B, history of prior MI, C, drinking more than 8 alcoholic drinks per week, or D, history of diabetes? If you said A, age greater than 80, you are correct. An increased age is both a thrombotic and a bleed risk, whereas a history of prior MI is a thrombotic risk. Drinking more than 8 alcoholic drinks per week is a bleed risk, and history of diabetes is a thrombotic risk. The CHA2DS2-VASc or CHA2DS2-VA score are mentioned in both the American and European atrial fibrillation guidelines, but what about applications specifically for patients with cancer? Thankfully, the ESC cardio-oncology guidelines do provide a little more specific guidance for these patients. They first highlight the fact that the CHA2DS2-VASc score should be considered for risk stratification. However, it is only given a Class 2A recommendation as there is a risk that the score underestimates the actual thromboembolic risk in cancer patients. Aligning with standard atrial fibrillation guidelines, they do provide a Class 1 recommendation for long-term anticoagulation in any male with a CHA2DS2-VASc of 2 or female with a score of 3. However, they also give a Class 2A recommendation to still consider anticoagulation in patients with cancer and a lower CHA2DS2-VASc score of either 1 in men or 2 in women. And even in patients who have little to no risk factors aside from their gender, they still highlight the fact that cancer may put these patients at a higher thrombotic risk and therefore mention it is worth considering anticoagulation after consideration of bleed risk. Lastly, due to the complexity and variability of these patients, a Class 1 recommendation is given for thromboembolic and bleeding risk assessment of these patients when they are seen for follow-up. Even though the cardio-oncology guidelines provide recommendations based off CHA2DS2-VASc scores, we do have to use the score with caution as it has not been extensively validated in patients with cancer. And there was a Danish study that found that patients who had lower CHA2DS2-VASc scores of 0 and 1 and recent cancer were linked with a higher risk of stroke or thromboembolism at 2 years than in patients without recent cancer. There are a couple of other conflicting studies that have sought to assess the use of the CHA2DS2-VASc score, as well as thromboembolic and bleeding risks in this patient population. Leader and colleagues conducted a retrospective cohort study in patients who had atrial fibrillation, as well as a CHA2DS2-VASc score of 0 to 2, who were not receiving anticoagulation at the time of cancer diagnosis, or the matched index date for individuals who did not have cancer. And looking at 12 months after the index date, they found that individuals newly diagnosed with cancer experienced significantly more arterial thromboembolic events compared to those without cancer. Therefore, the takeaway from that study was that we need to consider anticoagulating patients newly diagnosed with cancer who have lower CHA2DS2-VASc scores. However, Elregs and colleagues provide a different perspective. They looked at patients with AFib who were diagnosed with malignancy within 5 years before AFib diagnosis and matched them to cancer-free control subjects based on a variety of factors, including CHA2DS2-VASc score. Unlike the previous study where patients could not be on anticoagulation at study index, this study adjusted for patients who were on anticoagulation and found that atrial fibrillation in combination with malignancy did not put patients at a higher risk of having a stroke, but instead actually put patients at a higher risk of bleeding, with the greatest risk of bleeding being in patients with leukemia, lung, and GI tract malignancies. Therefore, this study does not support the argument for utilizing anticoagulation in patients with lower CHA2DS2-VASc scores, as they did not identify cancer as an increased risk factor for stroke. Elreys and colleagues provide some pretty harsh critique of the study conducted by Leader and colleagues, beginning with the fact that in patients with a CHA2DS2-VASc score of 0 to 2, anticoagulation was handled as a competing risk. They were critical of this because it assumes that people can never have a stroke after starting anticoagulation. Additionally, in the study by Leader and colleagues, interruption or discontinuation of anticoagulation that was started was not taken into account. Therefore, this could have lowered the estimate of stroke incidence in people without malignancy, as they would be less likely to have anticoagulation interrupted. Lastly, the fact that Leader and colleagues set the index date as that of cancer diagnosis versus atrial fibrillation diagnosis may not have captured patients early on in their atrial fibrillation disease course. Alright, so how are we feeling about the decision to anticoagulate? Does it seem crystal clear or clear as mud? If you said clear as mud, I don't blame you. As pharmacists, I know many of us like when things are black and white, or at least I know that I do. However, it seems oftentimes we are forced to live in the gray. My goal is to be able to give you as many tools as possible to help guide your decision. Thankfully, both the American Society of Clinical Oncology as well as the American Heart Association have provided flowcharts to help guide us through that decision-making process. Similar to previous guidelines discussed, ASCO recommends use of CHA2DS2-VASc score to assess whether a patient has a high enough score to consider anticoagulation. If a patient does not have a score of at least 2, they recommend against use of anticoagulation. If a patient has a score of at least 2, they recommend you move forward with assessing the patient's bleed risk. And one of my favorite parts about this guidance document is that they highlight more of the cancer-specific bleeding risk factors that are not accounted for in the HAS-BLED score, such as whether patients have a GI mass or metastatic disease. And based on the number of bleeding risk factors, they do provide recommendations on whether or not to move forward with anticoagulation. If a patient has any major risk factors or more than one minor risk factors, they recommend against using anticoagulation while the risk factor is present. In patients with one minor risk factor, they recommend to anticoagulate only in patients with a higher CHA2DS2-VASc score of at least 6. Finally, if patients don't have any risk factors, they say anticoagulation is generally recommended. The American Heart Association provides their own flowchart. If patients do not have a CHA2DS2-VASc score of at least 2 for males or 3 for females, they do not recommend anticoagulation. If patients meet criteria for anticoagulation based on CHA2DS2-VASc, they recommend to assess a HAS-BLED score as well as platelet count. If patients do not have a high HAS-BLED and have platelets greater than 50,000, then they say you can proceed with considering anticoagulation. However, if not, they highlight the importance of a shared decision with the multidisciplinary team and patient ultimately weighing the risk versus benefit. They also suggest consideration of a left atrial appendage occlusion device, which is a device that blocks off the part of the heart that has the highest risk of pooling blood and causing a thromboembolic event. And with this device, they can have an abbreviated course of anticoagulation. If the decision is made to proceed with anticoagulation, which agent do you choose? The ESC cardio-oncology guidelines do provide recommendations, although you can see none are listed as Class 1. As with all things in this patient population, everything comes with its own risk versus benefits. In general, NOACs, or DOACs, as we refer to them in America, should be considered in preference to low molecular weight heparin or vitamin K antagonists unless patients require warfarin for mechanical heart or valvular disease. In patients who are not suitable for a NOAC or a DOAC, they provide a Class 2A recommendation stating that you can consider use of low molecular weight heparin. And then in patients who cannot receive anticoagulation but have a life expectancy of greater than a year, they do recommend patients consider left atrial appendage occlusion. Lastly, they do highlight that antiplatelet therapy or prophylactic low molecular weight heparin are not recommended for stroke or systemic thromboembolism prevention. Now we will look at some of the pros and cons of each agent, as well as some practical considerations for use in these patients. Beginning with warfarin, some of the advantages include that it can be quantitatively monitored, it is not renally excreted, so it can be used in patients with renal disease. Efficacy is less affected by one dose in comparison to other forms of anticoagulation, and it is the optimal choice for patients with valvular atrial fibrillation. Some of the disadvantages include its long half-life, especially for patients who require surgery. There is a narrow therapeutic window, and as you all know, there are several drug and food interactions. It is also associated with a higher intracranial bleed risk, and in cancer patients, there is a lower likelihood of achieving time and therapeutic range due to vomiting, malnutrition, and potential hepatic dysfunction. And as far as some practical considerations, if you do have to use warfarin, it is recommended that at the beginning of cancer treatment to check the INR more frequently, pretty much weekly. And if you identify their time and therapeutic range to be poor, consider switching to another anticoagulation option if able. Next, we have our DOACs. They are helpful for having a rapid onset of action, shorter half-life, therefore less time to spontaneous reversal, more predictable PK and therapeutic margin, therefore we do not routinely monitor patients. Additionally, they are associated with a low risk of intracranial hemorrhage. Some of the disadvantages include the fact that they are only approved for non-valvular atrial fibrillation. Monitoring tests are not available everywhere if you do want to monitor. Patients may accumulate drug in the case of impaired renal and hepatic dysfunction. And the fact that they have a shorter half-life means that patients are at a higher risk if they do miss one dose. Additionally, there are still many drug interactions and they do have an increased risk of GI bleeding, except for apixaban. As for practical considerations, it is important to monitor renal function for these patients regularly. One of the reasons why we likely do not have a Class 1 recommendation for DOACs in cancer patients is that they have largely been underrepresented in major landmark trials. ROCKET-AF, the landmark trial for rivaroxaban, included only 5% of patients with cancer at screening, and as you can see on the right-hand column, they did exclude several cancer-related criteria, such as cancer within 6 months, anemia, low platelets, etc. And this is a common theme, as you will see on the next couple of slides. Aristotle, the landmark trial for apixaban, had slightly more patients with cancer than ROCKET-AF, however still less than 10%, and they also had several exclusion criteria related to cancer. Engage-TIMI for edoxaban, again, only had about 5% of patients with cancer post-randomization and also had a long list of exclusion criteria related to cancer. Finally, RELY for dabigatran did not provide information on whether or not patients had cancer, but did have several cancer-related exclusion criteria. Last but not least, we have low molecular weight heparin. Advantages include the fact that it does have a rapid onset of action and short half-life. The PK is usually predictable. There are little to no drug interactions, which is a huge plus. Another major bonus is the fact that the parenteral administration is helpful for those who experience vomiting. However, disadvantages include the fact that it is expensive, it does have to be renal dose adjusted, and there is no evidence for stroke or systemic embolism prevention in atrial fibrillation, and patients are likely to have low compliance due to discomfort of parenteral route. Therefore, practical use of low molecular weight heparin is generally not recommended. One of the studies that caught my attention when I was doubting the lack of efficacy of low molecular weight heparin was this one conducted by Oliveira and colleagues in patients with non-valvular atrial fibrillation with active cancer therapy. 110 patients who received low molecular weight heparin were compared to 192 patients who received a DOAC. After about 12 to 14 months, they found that there was a significantly higher incidence of stroke or systemic embolism in patients in the low molecular weight heparin group compared to the DOAC group. When looking at major bleeding, there was not a statistical difference. Therefore, the takeaway from the study was that stroke and systemic embolism rate increased in the low molecular weight heparin group without significant differences in major bleeding. However, one of the limitations of the study is that they did not define full, intermediate, or prophylactic dosing of low molecular weight heparin, so while most patients receive what they deem as full dose, it is hard to confirm or extrapolate the data. Even with anticoagulation, drug interactions are still quite common with our anti-cancer agents. Here is another table for your reference highlighting some of the pertinent interactions. Again, I highlighted some of the medications I discussed at the beginning of the presentation, including doxorubicin and ibrutinib. One more great reference I want to introduce you to is this AHA scientific statement specific to cardio-oncology drug interactions. They organize the interactions by enzyme, which I think can be a helpful way to look at it. Here is an example for CYP1A2 enzyme. As you can see, it breaks it down by drug class, substrates, inhibitors, and inducers. Another tool to add to your toolkit to make managing these patients a little less scary. As we near the end, I have provided this image, which consolidates a lot of the key information we have discussed related to selecting a rate control strategy versus a rhythm control strategy in patients with atrial fibrillation and cancer. As a quick reminder, you can see the strategy and agent deemed to be the most safe in this patient population is rate control with a beta blocker. Additionally, this document consolidates the AHA recommendations for anticoagulation and includes a lot of helpful pearls to serve as a quick reference. In conclusion, when it comes to managing these patients, it's important to remember that a multidisciplinary team involvement is critical as each patient is unique. It's also important to prioritize early identification of modifiable risk factors and to remember that beta blockers are often preferred over antiarrhythmic therapy. Also important to screen every patient for drug-drug interactions. And finally, we have to cautiously utilize scoring tools to be able to assess thromboembolic and bleed risk in these patients prior to initiating anticoagulation. Thank you all so much for your time and for listening today. Here is a list of resources that I have utilized to create this presentation, as well as a few more on this slide. If you have any questions, I have provided my email on the screen. I would be happy to get back with you. Provided on the screen is the code to be able to receive CBE credit. Thank you again so much for your time.